information about managing IBD. So we can find it in the British Society of Gastroenterology IBD guidelines, BSG 2019, and all encompassing text covering various aspects of IBD management. So if you could just link or copy paste the link, it will take you straight away to the BSG guideline. So are you ready, guys, for the first case? So Carl will present the first case.
Hi guys, so the first case is a 35-year-old lady who's come in with increasing bloody diarrhea. So her background is she's got ulcerative colitis, which was initially diagnosed 5 years ago and has been stable on Octasa normally. But in the last few weeks, she's noticed to have increasing bloody diarrhea with bowels opening up to 9 times a day. She's called her IBD nurse, who started her on prednisolone, 40 milligram once a day, but her symptoms haven't improved after 3 days. So she's now been advised to be admitted to AMU for further treatment. Next slide, please. So the question we wanted to ask you guys, and if you can answer in the in the chat, is like, how would you assess this patient? What sort of information would you want to have to further categorize, in like the severity of this patient's ulcerative colitis, and therefore, like, how would you manage it?
So just feel free to answer a question, say anything. If that lady came to you in AMU or A&E, how to approach such patient. What, like, yeah. So, yeah, but before that, like in terms of like from the basic, like history and examination, do you just like want to ask a couple of, to just like to stain certain points in the history and examination before doing the clinical bits? Sorry? Okay. And then what else? Plus what? Sorry? Yeah, that's a good point. So in terms of history, just like if someone coming with bloody diarrhea and there's background of, we know that's an IBD, do we just like take it for granted IBD and we treat it straightforward as an IBD, or do we need to exclude other possibility as well? Just like we need to like widen our scope. Not every just like bloody diarrhea might be just like an ulcerative colitis or like an IBD. So there's any question that we need to ask like for this patient? Sorry, could you just like hear your yeah. Yes, well done. Yes, so the history of travel, so you need to rule out these should be just like ABC for any patient with a diarrhea, bloody diarrhea. The first thing we need to rule out infection. If there is a established diagnosis of IBD before or no, so the first thing is like infection. Ask about the history of travel. Ask about any family member who have a diarrhea. Ask about any like recent food, or ask about any recent history of antibiotic use. So the other differential diagnosis for such patient is C. diff infection, which is really common, and particularly patient with a background of inflammatory bowel disease, they do have a high risk of C. diff infection. So don't ignore the asking about simple things, antibiotic use. Ask about the BBI, because antibiotic use or BBI can predispose such patient to C. diff infection, which is really important differential diagnosis in the history. So these are really important thing. Just anything else on the history or examination wise, guys? Those on online, just feel free also to comment on this. Because sometimes can present like first time, and you need to ask history of smoking, family history as well, details on the color, the frequency of the stool, and the bloods as well. So because like the number of stool will tell you the severity of the IBD as well. If someone have like a 4 times, it's not like someone have a 16 times per day. So you need to touch on that as well, on how the frequency, the consistency, the fever, the malaise, weight loss, symptoms of extra intestinal manifestation like joint pain, eye, rashes as well. You need to ask. So, and after that, you'll embark on examination. You should just like do a proper examination, pulse, temperature, abdominal examination, to see if there's any distension. Sometimes you need to rule out the surgical stuff. So you need to examine the patient to see if there's any mass or any distension as well. So these examination history. In terms of workup, what do you think, guys? What we'll do for such patient in a practice? Say anything. Stool sample. Yeah. For yeah, for microscopy and culture, C. diff as well. Yeah. And then abdominal X-ray. Why? Yeah, throughout toxic megacolon. Yeah. And then what else? Urea and electrolyte, CRP, ESR, and all the routine investigation. So for this patient, the pulse was 105, blood pressure was 100/70, respiratory rate was 10, SAT was 99 on air, and soft abdomen, no guarding. Next car. So to assess the severity of colitis, if the diagnosis of the colitis was established, and you need to assess if the severity of the patient. So we got a Trulove and Witt's criteria for acute severe ulcerative colitis. So we recommend that the adult patient with acute severe ulcerative colitis are defined by modified Trulove and Witt criteria as more than 6 bloody stool per day, and one of this systemic toxicity manifestation, either temperature more than 37.8 centigrade, or pulse more than 90, hemoglobin less than 105 gram per liter, or CRP more than 30. So more than 6 and plus one of this will deem the patient to have an acute severe ulcerative colitis. So next. So do we hear about fecal calprotectin? So fecal calprotectin can be done as for those who's established to have ulcerative colitis, or it can help us like to diagnose the patient who's coming on a first time with a bloody diarrhea. We don't know whether this patient have an IBD or no. So if the patient just like for example, someone who's like first presentation came in with calprotectin with 200, this will deem him for just like to further investigate on IBD. But if someone like known to have IBD came in with high calprotectin, that's mean there is an ongoing inflammation. So you'll do bloods to look for the hemoglobin, for CRB. You'll do stool culture, as you said, for C. diff and other MCNS. Abdominal X-ray for to rule out toxic megacolon. And sorry guys. And we do use flexible sigmoidoscopy. We don't do the full colonoscopy. Do you know why, guys? In someone coming just like fresh with IBD or suspected IBD, why we are going for flexible, not for the full colonoscopy? Yes, yeah, there is a high chance of perforation if we are going for complete sigmoidoscopy. So we go for flexible one, and we are using UC index for index score to this like endoscopic classification to see the severity of the UC. So this patient, our UCIS score was 5. So there was ulceration and a small amount of spontaneous bleeding. Next, car. So how to interpret the UC severity throughout the endoscopy? So it depends on a factor of vascularity and on the bleeding and ulceration. Normal, like the normal one is there on the A. You can see the vascular capillary is there. If there is obliteration of the capillary, that's mean there is inflammation. And after that, you look for the ulcer and how deep, and you look for the bleeding. Is it like luminal or is it like mucosal bleeding? So there is a 3 categories. The more the obliteration of capillaries, the more the inflammation. And you'll see how deep the ulcer is there. If you can see there on G, there is an awful ulceration there, and deep ulcer, that's mean it's like severe. Yeah. So next. So this is patient started usually the treatment for ulcerative colitis or acute ulcerative colitis is hydrocortisone 100 milligram QDS. I think all of us, we know that. Should we start clexane for such patient? If someone coming with a bleeding like CV bleeding, rectal bleeding, shall we start the clexane? Yeah. Why? Sorry? Yeah, they are really pro-thrombotic. So some people, they say just like these are common pitfall. Some doctor, they say just like they are coming with rectal bleeding, we should just like avoid the clexane because she going to bleed more. No, they are pro-thrombotic. So you need to start clexane immediately. After 3 days of IV hydrocortisone, patient has shown little improvement in diarrhea. What should you do next? Sorry? Surgical review. Yeah, this is good point. So there's any criteria that you can refer to surgery, or just like day 3, there's no response, immediately surgery? There's anything that can give you hints, like whether to refer to surgery or no? Look like if we can say just like true love and wits criteria on day 3, just like if it's still the patient like still symptomatic, having more than 6 diarrhea, is still like septic, anemic, low albumin, there's a feature that can give you like a clue to refer to surgery. And X-ray on day 3. Day 3 always do X-ray. If there's no response, still the patient have like a diarrhea, do X-ray to exclude toxic megacolon as well. So in terms of management, what do we use? Like anyone have experience on like you give hydrocortisone QDS or you give methylprednisolone like for 3 days and there is no any response? So in terms of management, there is any sort of medical treatment at all? So we need to just like do a rescue therapy, either cyclosporine or infliximab. This like in gastro we do that. So so the infliximab can be used on a rescue treatment, not like a long term. It can induce remission and it can be just like used as a maintenance as well. So before starting someone on a biologic, you need to do something, isn't it? Like, so the side effect of biologic like infliximab or adalimumab, we know that's like it can predispose someone to infection, and if someone have a like tuberculosis or latent TB, it can reactivate his tuberculosis and can predispose patient to infection as well. So we need to send a couple of tests. It's called biologic screening. So next, Car. So what do you think about this on the 3rd day? Can you see anything, guys? Anything abnormal? Look like volvulus, but so the volvulus is like typical bean sign, is it? Like, but for this, if you see there, is that the diameter is like normal? Not at all, is it? These are typical toxic megacolon, actually. So this is a patient you need just like to refer immediately to the surgeon, and he might need a surgical resection. Next. That's the colon. So just like imagine really huge. It's like someone showing off there. So that's like, yeah, on the 3rd day, if someone just like still symptomatic and having abdominal pain, you need to have a like high index of suspicion of toxic megacolon. So next, Car. So this is general, not on this case. So on this case, on day 4, given infusion infliximab, 5 mg per kg, and hydrocortisone will continue. Day 7, there was improvement in diarrhea, bowels opening fourth time per day, and day 9, change to oral prednisolone. So when we are switching to oral prednisolone, so don't send patient just like if you switch it on the same day, we need to see the response. So in the morning, let the patient have his hydrocortisone dose, and at the same time give him his like 40 mg his prednisolone and see. So ideally, as per BSG guideline, you need to see to keep the patient for 24 hours to see if he is responding to prednisolone. Don't send them home prematurely, otherwise you don't know whether they will respond to prednisolone or no. So just keep the patient there, observe the clinical response, ask him about diarrhea if it's just like still continue to decrease. So, and after that you'll change it to prednisolone on day 11 discharge. So week 2 infusion date at the infusion unit booked. So from there the IBD nurse usually they are really good, and they will follow the patient on a regular infliximab sessions. Next. So these are management general. So as a doctor in inpatient, you need just like to be cautious on taking good history, rule out these are, to summarize everything. You need to rule out the infective cause. You need to rule out the C. diff infection, recent antibiotic use, and to start the patient on a steroid as soon as possible. So if you send the, don't wait for the culture to come. There is no harm to start the IV hydrocortisone. So there is no harm to just start the patient on Clexane. Don't be afraid of like this could be just like bleeding. If someone have a background of IBD, you know that he got an IBD, so you need to start him on a Clexane. Start hydrocortisone. Don't wait for the culture. Do the other workup as well. If you have like any doubts, there's no diagnosis, just send for calprotectin as well. Fecal calprotectin can give you the clue. And after that, like couple of maybe second day or third day, we can send the patient on next day to flexible endoscopy to tissue diagnose him. IV fluid, make sure that patient just like hydrated as well, and painkiller. Try to avoid the antispasmodic as well, and the opiates as possible, and have high index of suspicion of the complication like toxic megacolon. And so there is another surgical condition that's might deemed a surgical input, like perforation, continuous rectal bleeding. You need to involve the surgical. So the key point is like early involvement of the surgery. So just if you have suspicion that your patient is not going to the right way, involve them early, because if it became late, the surgical, I think, intervention, it will carry high mortality, and the output will not be optimized as someone just like involved earlier. Here, these are summary of the treatment according to BSG, or British Society of Gastroenterology. So just like to summarize, if the patient just like more than 16 years old, at the beginning you need to do like microscopy C. diff, and if someone like less than 16 years old, you need to follow the European Crohn's and colitis guidance, or European hepatology and gastroenterology and nutrition society. So you need to commence the patient on hydrocortisone 100 milligram 6 hourly, or methyl prednisolone 60 to 80 milligram daily, and low molecular heparin prophylaxis. Usually such patient will come with their 5-ASA, so you need to consider withholding 5-ASA. When we switch the patient to oral prednisolone, just like you can switch him or her to his 5-ASA, like Asacol or Mesalazine, or whatever 5-ASA that he's taking. And you need to offer the patient sigmoidoscopy as well within 24 hours. And the other differential diagnosis, you need to take a CMV as well. So we will do cytology. We'll take a snip from the rectum so as to rule out CMV. So we can see inclusion body there. So CMV colitis can present with similarly with a bloody diarrhea. So we need to rule out that as well. So on day 3, as we said, so to see if the bowel movement more than 8, or if it is like between 3 and 8 bowel movement per day, and CRB more than 45 milligram per liter, you need a surgical review. So these are our criteria. If the bowel more than 8, or between 3 and 8 with a CRB high, involve surgical, whether colectomy require. If the colectomy is not required, as we said, rescue treatment, infliximab, 5 milligram per kg, or IV cyclosporine, 2 milligram per kg. If the bowel is less than 4, after that we need to switch to prednisolone 40 milligram and convince cerebrine, if not already receive it, as a cerebrine, and restart 5-ASA if it is held. If no, that means the patient might need colectomy. So next. So I think there is a lot of biologic. You didn't need just to worry about it, but you need to familiarize yourself with a type of biologic that you are using in IBD. Most commonly, we are using infliximab. So it's called anti-TNF, or so in anti-TNF there is infliximab, there is adalimumab, and there is golimumab. So these are famous anti-TNF. And sometimes we see some patients, they are not responding to infliximab, or they are just developing allergic reaction to it. So we switch them to vedolizumab, which can be used as in remission, inducing remission, and as an maintenance therapy as well. So we do see some patient there on infliximab or adalimumab came into the hospital. We start them on hydrocortisone, and he received it weeks ago. He received 2 weeks ago. He received his adalimumab. So usually the IBD nurse will be involved. So what they will do, they will escalate the pre-existing biologic. For example, if he's taking it every 2 weeks, so it will be every week. So escalation of the duration. Next. So how to screen for biologics? You know, guys? Chest X-ray. Yeah, T-spot. Yeah, chest X-ray to rule out the possibility of tuberculosis as well. T-spot. What else? Hepatitis as well. Next. Car. So T-spot, hepatitis B, hepatitis C, varicella, IgG, HIV, and chest X-ray, as you said. Next. So Car.
So we have the next case. So it's an 18-year-old female who was diagnosed a year ago with perianal ileocolonic Crohn's and is currently on azathioprine. So she's been admitted with fever, temperature of 38 degrees, and acute abdominal pain. So her observations are as follows, and her bloods are back, and it showed quite a raised CRP and low hemoglobin, as well as a really raised white cell count. So next we have to think about what sort of tests are we going to request in addition to what we already have, and should we be starting steroids at this point, and should we also be starting clexane as well? So if you could just comment as well, that'd be great.
What do you think, guys? What are your thoughts about this? Any particular tests? Just someone a background of heart background. What you'll do? Just anything different? So just we could just ask the same screening questions and do similar examination as well. But if someone just coming with these high CRP, she's febrile. Sorry, if you could just show us the slide, if you can go back as well. No, not this. The before this. Before that. Yeah. Come again. The history one. No, just like, yeah, this one. So temperature is like 38. CRB on the roof as well. And white cell count is high. And this patient have a Crohn's diagnosis, already known to have a Crohn's. And she's currently on azathioprine and admitted with fever and acute abdominal pain. So there is no diarrhea there, is it? Like someone just like came in with Crohn's, non-Crohn's, came in with acute abdominal pain and fevers. So like abdominal pain and fever. First things to think about it in such patient, what do you want to rule out? Any collection abscess. Yeah, exactly. If you can show this, like, so what the investigation of choice to do for such patient? CT scan. So historically, the people they are doing barium studies actually, and now it's replaced by the MRI and CT scan. So if you can see the car, if you could show us the CT scan. So if you can see there is a thickening there on the ileocecal area, and there is collection there as well. So there is like a collection on that area. So this patient need a surgical like input, either through like IR or like a surgical intervention. Next. So consider a CT to rule out an extra abdominal abscesses in Crohn's, especially with pyrexia and high CRB. So do not rush to steroid unless abscess rule out. Always seek a gastro opinion when in doubt. Starting IV antibiotic early on is advisable. Consider MBM or low risk diet. Early input from surgeon is important. So if someone like for Crohn's, we do see colitis more than Crohn's in the hospital setting actually. But if someone just with Crohn's disease coming with high CRB and febrile, think about abscess. Think about just like to scan them and to involve the surgical team. So we do see people who have a Crohn's disease coming with abscess, and it might come with intestinal obstruction as well, because it's like stricturing disease. It's notorious to have a intestinal obstruction. So it might come with this. Next. So 5 days of IV antibiotic, low risk diet, improvement in CRB and white cell count, discharge 10 days later, ileocolic resection bland in 3 months. Because there was a mass there. Next. So we have our trust guideline for IBD pathway for biologic. I think we didn't need to worry about that as a junior actually. So your duty to know what the differential diagnosis, how to investigate for such patient, and when to start the treatment and how to start it, and when to involve the early involvement of the surgical team. That's like of a paramount importance. Yeah. Next. So here there is a different type of mesalazine. It depends on the release actually. Some of it just like pH related, and some of it like depends on the bacteria to do the cleavage there. So usually the patient with ulcerative colitis, if it's like mild to moderate, we're using 5-ASA, and BSG recommends like to use both like systemic 5-ASA and local one, like what is like suppositories or enema or any form. So if there's no response on that, we can think about the topical steroid. And if there is no response after that, we should use like the IBD nurse. They start the patient on prednisolone, and if there's no response after oral prednisolone, so and if the diarrhea is like more than 6 times, so this patient merit hospital admission. You need to come and admitted and to be treated by the IV steroid. So, and before prednisolone, when he's in 5-ASA, usually they are taking 2 to 3 gram of 5-ASA. So the IBD nurse usually double the dose. Actually, you can see the patient before coming to the hospital, his dose escalated to 4.8 actually from 2.4, and after that she will start the prednisolone 40 over 6 to 8 weeks, and if there is no response, the patient will come to you in A&E or AMU to start the IV steroid, and if there is no response after that, as we said, after 3 days, we need to think about the rescue treatment in form of cyclosporine or infliximab, and we need to follow the complication, surgical complication, as we said, perforation, bleeding or toxic megacolon, and to have a high index of suspicion of surgical input and early involvement of surgical team. And the common pitfall is like people they are ignoring. We've seen a lot of patients in a gastro ward coming without Clexane, actually, without any prophylaxis for such patient with acute colitis. Can imagine prosympathetic condition without any prophylaxis. And we do know that the people that think no, don't go for Clexane. Yeah, this is common pitfall. And the other common pitfall is not that the delayed surgical involvement as well for such patient. Yeah, that's all. Thank you, guys. I don't know if Dr. Jivigan, you are there? Yeah. Any question, guys? This is like concise. The only it is like extensive topic actually, but these are most important bits as in the hospital you need to focus on. All right. Thank you, Dr. Jivigan. Any question? Thank you, guys. Car?
Thank you very much.
So Dr. Jivigan, I think you're at Crohn's, abdominal pain, CT first. So these advice from the consultant. So in the clinic, usually if someone coming with abdominal pain, and if I have a suspicion of could be just like IBD, I'll do calprotectin. But before that, I need to rule out the simplest thing, like thyroid function test, celiac screening, someone coming with abdominal pain and diarrhea, for example, as a general. This is not related to this topic actually. So you'll do the first thing. The differential diagnosis could be IBD, or could be thyroid, or could be celiac disease because it's common. So you will do this screening. If all this came negative, you'll do calprotectin. So calprotectin by itself could be just like, can give you a clue, like if it's like more than 200. So some clinicians, they will repeat it again. Actually, if there is a significant rise on 500, that's it. Just like send the patient for colonoscopy or sigmoidoscopy. Otherwise, if you need a non-invasive thing, you can do MRI if you have suspicion. Like you can do MRI bowel. It can tell you about if there is any feature of Crohn's disease. Yeah. Cool. Thank you very much, guys. Thank you. I just prepared quickly, just like overnight.